So I have the pleasure to introduce our next speakers, Professor David Porteous and Dr. Chloe Fawns-Ritchie, who are speaking on Generation Scotland's response to COVID-19 and understanding the mental health impacts. It's a real honour to introduce both Professor Porteous and Dr. Fawns-Ritchie. Professor Porteous has published over 400 research papers. His work has been on the application of knowledge from the Human Genome Project to identification of risk factors, disease processes, and new treatments for a range of common disorders. Notably, his research in psychiatry has identified several major risk genes for risk of developing schizophrenia and bipolar disorder. Most well known is the DISC1 gene, one of the most validated genes. He is a fellow of the Academy of Medical Sciences of the Royal Society of Edinburgh, and here an honorary fellow of the Royal College of Physicians in Edinburgh, and received the OBE for contributions to science. Professor Porteous conceived and initiated Generation Scotland. Dr. Chloe Fawns-Ritchie is a postdoctoral research fellow with Generation Scotland, leading the development of online questionnaires. Her research focuses on the psychological correlates and predictors of health, and previously Chloe helped develop the cognitive assessments used in the UK Biobank and the Healthy Ageing in Scotland study. It is a real privilege and honour to introduce you both and give you to the floor. Thank you.
Thank you, Andrew. I hope you can all hear me. Chloe's going to be showing the slides, and I'm going to just kick off and just start with a somewhat poignant point, which is that the last time I was in a face-to-face meeting of any large size, it was actually in the Royal College, and it was in very early March 2020. We thought we were going to be with you in person, but I understand why we are meeting remotely. I'm going to just set the scene for you to say a little bit about Generation Scotland and how we've been adapting to COVID-19. But just let me tell you what Generation Scotland is at its heart. It's a longitudinal study of the people in Scotland from childhood to old age. We have already recruited 24,000 adults. They're in 7,000 family groups. And the recruitment was primarily in the period 2006 to 2011. What we did was ask them to come to a clinic, have lots of measures made, and also to ask them to answer a long list of health and well-being questionnaires. We collected samples to do genetic studies and biochemistry on, and crucially, we linked all of their information with their consent to NHS Scotland health records, and crucially also to recontact them for follow-on studies. So this is very much a study aimed at using the very best of health data science for predictive medicine. The next slide just illustrates how far we've come. Through this study, we've got over 200,000 person years worth of health data, amounting to tens of millions of data points. And the way we've been able to do that is by setting up a very safe and secure way of linking NHS Scotland data, both primary care and hospital-based, to the biochemistry studies that are carried out routinely, and on through to prescription data, and then link that to our Generation Scotland self-generated data. And we've made sure right from the beginning that we paid equal attention to measures of physical health and to mental health. The next slide just gives you an example of what we've done to date, and this is one of the great powers of Generation Scotland, is being able to embed other studies within it. Most notably, the Straddle Enhancement Study, led by Andrew McIntosh, where we've looked at how we can stratify resilience and depression longitudinally. And what this has been able to do is to give us really good measures of what matters most and quantify those, where the balance lies between a family history, between genes and the environment, personality, lifestyle, and thinking skills and brain processing. And through that kind of work, we're starting to get new clues about the biological underpinning of risk, of new targets for treatment, how we might think about repurposing existing drugs, all towards precision medicine. In the next slide, I want to just give you a very quick snapshot of what we're doing next and how we've had to change our plans, because the Wellcome Trust has come up with a substantial funding for us starting in November 2019, where we aim to at least double the size of the cohort and crucially recruit from age 12 and up. And not just relying on Scottish NHS data, but also administrative records, and moving online to be more inclusive, to collect data more passively through mobile phones and activity apps, and to rely on postal sample collections, again, for improved accessibility for others to engage in the study. The last slide in my section, it really emphasizes why age 12 and up. Well, we all know that adolescence is a period of hormonal, physical and physiological change and thus vulnerability. So what we want to do is to start to be able to recruit that younger age group and capture information on them as they go through that period of rapid learning and brain development. And we see that very much as a window of opportunity for intervention and prevention. But of course, all of those plans were put on hold. So the real theme of today is to tell you how we've adapted. And so I'm passing over to Chloe now, who's going to tell you all about that.
David, I hope everyone can hear me. I'm sure you'll let me know if you can. So we were planning to recruit new participants, but unfortunately COVID prevented that. So we pivoted to carrying out studies to better understand how people were feeling and coping during COVID-19. And we have carried out 3 sets of studies to date, so COVID Life, Teen COVID Life and Rural COVID Life. But for the purpose of today, I'm really going to focus on our COVID Life study and tell you a bit about what we did and what various people are now finding using this data. So COVID Life was set up to understand the psychological, social and economic impact that COVID-19 was having on adults living in the UK. The idea was that we would recruit participants early in the pandemic and then follow them up over time. And this was entirely an online survey, so participants were completing questionnaires online. Our first COVID Life study had just over 18,500 people take part, and we followed on 2 other occasions since then. About 2/3 of the sample reported that they were female, and although we recruited participants, or participants were eligible to take part from anywhere in the UK, because of our recruitment strategy, most of our participants were from Scotland. Again, because of our recruitment strategy, most of the participants in COVID Life are middle-aged and older adults, but we do have pretty good numbers of younger participants as well. And you can see the timeline at the bottom there. We've followed participants up on 3 occasions. The first being quite early in the pandemic, so that's sort of April to June 2020 when we're in that first lockdown. We then saw that I asked them to complete questionnaires again in summertime last year, and that's when the restrictions had eased quite a bit, so people were able to go out and see friends and family again during that time. And our final study took part in February this year, which was in another full lockdown. So here's just an example of some of the topics that we assessed in COVID Life. Primarily, we were interested in how people were feeling and coping, so there was quite an emphasis on mental health, so we have assessments of anxiety and depressive symptoms. We asked about loneliness, stress, isolation, things like that. But by no means was that our only interest in COVID Life. We have quite a range of different topics. And we asked about, for example, whether people were following the guidelines around COVID, whether they agreed with them, whether they think they've had COVID, long COVID, whether they were getting vaccinated, things like that. And importantly, we invited Generation Scotland participants to take part in COVID Life. And just over 4,800 Generation Scotland participants did complete the COVID Life survey. And this means that for this subsample of participants, we can link their COVID Life responses to the pre-pandemic data we have on these participants. So we can link it to sort of health and well-being measures, which were assessed many years before COVID-19. We can link the responses to genetic and biochemistry data in this sample. And I think most importantly, we can link their COVID Life responses to NHS Scotland health records. So that means that in this subsample, we have the ability to look at health predictors of coping during COVID-19, but also the health consequences, the future health consequences of COVID-19 as well. So that's a really brief introduction into what we did during with our COVID Life study. This data is now being used by both researchers on the Generation Scotland team, but also collaborators around the UK and actually elsewhere in the world to better understand the impact of mental health during COVID. So I'm just going to tell you about a few studies, a few of the results that have been found using the COVID Life data now. So we were quite interested in loneliness during COVID Life, during COVID-19, and we asked about loneliness at each wave of COVID Life. So we asked people how lonely they felt during the past week. But we were also interested in trying to figure out how lonely people were before COVID as a comparison. So in COVID Life 1, we also asked participants to think back to before COVID and tell us how lonely they were feeling then. And for each of these questions, participants could answer that they were feeling lonely none, some, most, or all of the time. So I'm now going to show you the percentage of participants who reported feeling lonely before COVID and at COVID Life Wave 1, 2 and 3. So this is the report, the figure for before COVID-19. So when we asked them to think back to January 2020, it's separated by age. So you've got the youngest participants on the left-hand side, all the way up to the oldest participants on the right-hand side. The light blue is the percentage reporting that they felt lonely almost never. And then you've got anything more than that, anything darker than that is that they've reported feeling lonely at least some of the time. So this is before COVID-19. And what you'll notice is that there's quite a difference between age groups. So younger people are reporting feeling more lonely during than older age groups. So this is before COVID-19. So how does this change when we go into that first lockdown? Okay, here we go. You'll see that there's a lot less light blue here. So during that first lockdown, there's a much higher percentage of participants saying that they feel lonely than they did or they remembered feeling before lockdown. And this increase is seen across all age groups. So then we followed them up in COVID Life 2, which was summertime 2020. So when the restrictions had eased, you could see friends and family. How does loneliness change? Okay, ready? So loneliness went down quite a bit during that summertime compared to the first lockdown. People were not feeling as lonely as they were during that first lockdown. And then unfortunately, we went back into another lockdown at the start of this year. So do we find that loneliness increased? Yeah, we did. So what we were finding is that during periods of lockdown, people were feeling much more lonely than when the restrictions had eased and before lockdown, which I suppose is no great surprise to anyone. One of the key benefits to COVID Life is that we asked the same or relatively similar questions to our participants as other studies around the UK were asking to their participants as well. That, along with the fact that we have the subsample of COVID Life participants with pre-pandemic data, those that completed Generation Scotland, has allowed us to work collaboratively with other groups around the UK to combine our results to try and better understand the impact of mental health during COVID-19. And I'm going to tell you just about two of the studies which have recently been published looking at this. So the first, which was led by Alex Kwong and Rebecca Pearson, was interested in determining what's associated with levels of depression and anxiety during COVID-19. And they looked at two cohorts in this study. So firstly, they looked at the Generation Scotland subsample of COVID Life, and they had about a mean age of 59 years. They also used participants from the Avon Longitudinal Study of Parents and Children, or ELSPAC. And ELSPAC was a study where they recruited children born in 1991 and their parents. So here they've separated the participants from ELSPAC into the parent group, which have a very similar mean age to Generation Scotland participants, and the younger participants, which have a mean age of about 28 years during COVID. What's important about Generation Scotland and ELSPAC is that they have depressive and anxiety symptoms measured both before COVID-19 and during COVID-19. So what this study wanted to look at is whether there were factors which were associated with depression and anxiety during COVID-19, accounting for pre-pandemic depression and anxiety. So here the results are reported separately by group. So we have the triangles are the ELSPAC parents, the circles are ELSPAC, the younger participants, and the squares are the Generation in Scotland participants. So here they're looking to see are socio-demographic variables associated with depression and anxiety during COVID. And for some, there was fairly consistent results across all groups. So reporting being female and reporting financial problems was associated with higher depressive symptom scores, so that is with worse mood. And there were some associations which were only seen in the older age group, so that's in ILSPAC parents and the Generation Scotland participants. So being older and having a higher income was associated with lower depressive symptom scores, so better mood. And having lower education and a higher deprivation was associated with increased deprivation scores. What about for anxiety? Similarly, we find that female sex is associated with worse anxiety scores. Higher deprivation was also associated with worse anxiety scores, and that was across all groups. Again, for older adults, for older age, you only found that in the two older age groups, so ILSPAC parents and Generation Scotland. Here, being older was associated with lower anxiety symptom scores, so with better mood. The study was also interested in looking at whether there were physical health and factors related to COVID-19 that were associated with depression and anxiety. And for depression, we found that quite a lot of them were. So having a history of obesity, reporting that you've had or you think you've had a COVID-19 infection, reporting that you were self-isolating, living alone, and not having access to a garden were consistently across all groups looked at associated with higher depression scores, so with poorer mood. And for anxiety, we found that a history of obesity and reporting that you were self-isolating were also associated with higher anxiety symptoms. So this study was found that a range of demographic, health and COVID-19 factors were associated with increased risk of depression and anxiety during COVID. And this is especially true for female sex, younger age, deprivation and a history of obesity. Importantly, these results were found independent of pre-pandemic depression and anxiety. These results are not surprising and are in line with what was being reported elsewhere in the world. So there's a recent systematic review which found that female sex and younger age was associated with greater burden of depressive and anxiety symptoms during COVID-19. But what about people who had mental health conditions prior to COVID-19? Or how were they coping during COVID-19? This study here, which was recently published in the British Journal of Psychiatry, looked to see whether those with poorer mental health before COVID-19 suffered from greater disruption during COVID-19. Now, this was part of the National Core Studies COVID-19 Longitudinal Health Wellbeing Initiative. This initiative was set up to allow population health studies in the UK to work collaboratively together to coordinate analyses. And this particular study was based on data from just under 60,000 participants from 12 longitudinal studies. And these studies had measures of pre-pandemic psychological distress, and they also assessed disruption, various indicators of disruption during COVID. Now, all of these studies are slightly different. Some of them use different mental health measures, different populations, different timeframes, and even different survey designs. And the idea is that if you bring all the results together, you can hopefully reduce the bias in your results. So they looked at 3 sets of disruption during COVID-19. They looked at healthcare disruption, which was things like not being able to access medication or missed or cancelled or postponed procedures or appointments, medical procedures or appointments. They looked at economic activity disruption, which could be losing your job, loss of income, being furloughed, changes to your working hours. And the final disruption was housing disruption, so whether participants lost their house during COVID or had to change address, or if there was anybody moving in and out of their house during COVID-19. So this figure reports the odds ratios, so anything to the right of this line indicates that having psychological distress before COVID-19 is associated with greater disruption, and anything to the left of the line says that it was associated with less disruption. Now, the results are reported here for each individual study, but we'll focus on only the black bar at the bottom, which is the combined results across all studies. So here we're looking at healthcare disruption, and it was found that those who had psychological distress before COVID-19 were much more likely to suffer from disruption to healthcare during COVID-19. Next, we looked at economic disruption, and again, it was found that people who had psychological distress prior to COVID-19 were more likely to experience economic disruption during COVID-19. And finally, we looked at housing disruption, but there was no association between pre-pandemic psychological distress and housing disruption. So this study found that pre-pandemic psychological distress, people with pre-pandemic psychological distress were more likely to experience disruption to healthcare and economic activity during COVID-19. And this was fairly consistent across 12 different studies, despite the studies being quite different. So that's a very quick introduction to COVID life, what we did and what researchers are beginning to find with COVID-19, with COVID life data. There are numerous other studies ongoing at the moment, and there's more planned in the future, so watch this space to find out more results from COVID life. Just quickly before we finish up, I'm going to tell you about the two other studies we've been carrying out, teen COVID life and rural COVID life. So Teen COVID Life was designed to give young people living in Scotland a voice to tell us how they were coping during COVID-19. There was many studies under COVID looking at how adults were coping, but very few focused on adolescents, and I suspect this was largely just a convenience thing. It's easier to recruit adults than it is to recruit teenagers. But teenagers went through an awful lot under COVID. The schools were cancelled, exams were cancelled, they were people trying to find a job for the first time when there was very few. It was a very difficult situation. So we carried out Teen COVID Life to give young people a voice to tell us how they were coping. And we've carried out 3 waves of Teen COVID Life, most recently in June this year. We've also carried out Rural COVID Life. In Scotland, rural communities make up 17% of the Scottish population, but they tend to be underrepresented in health research, again, largely for convenience reasons. It's much easier to recruit urban communities than rural communities. But we wanted to understand how people in rural communities what issues they were facing already and how this was changing under COVID. And this questionnaire was designed actually in partnership with rural communities to make sure that we were actually asking the appropriate questions. And we carried out this survey in October, November last year. We've got most of the topics in, there was a lot of overlap in the topics that we assessed in our rural COVID life and teen COVID life with our COVID life study, but each one had their own sort of unique topics that we were interested in. So within our teens, we were interested in asking about exam cancellations and schooling. Within our rural participants, we were interested in asking about their access to healthcare connectivity, which was obviously important in these communities. In communities where they don't have access, where access to internet is possibly not as good as it is for people living in cities. And all of this data is available for researchers to use. So if there's any data from Generation Scotland or any of our COVID life studies that you're interested in using, then there's more information on our website you can find. Now, just to finish up, it's David and I standing here presenting today, but this is very much a team effort. So just like to take this opportunity to thank all of the Generation Scotland team, our funders and our collaborators, without whom we would not be able to do this, be able to stand here and tell you about our studies. And if you're interested in finding out more about Generation Scotland, there's information on our website. You can follow us on social media, or please feel free to ask either David or myself some questions now. Thanks very much.
David and Chloe, thank you very, very much for a really excellent and inspiring talk. And I just want to, for those of you who are joining us online, if you have any questions that you would like to put forward for the discussion, then we have a Q&A online, and I can see those there if they come up. So do post any questions that you might have. We do have a few minutes. Some questions, and I was absolutely fascinated by the data presented, and particularly the strength of your findings in terms of impacts of COVID and the predictors of that in terms of female gender, deprivation, obesity, but also your findings in relation to the disruption, the impacts of disruption of healthcare, but also economic activities. And I guess, thinking about today, a kind of important theme of today's annual scientific meeting is thinking about, how do we navigate our kind of way, one, out of a pandemic, but also, I guess, into Alistair also talked about how we're going to see changes in NHS delivery with the refresh of the mental health strategy. And it would just be really interesting to hear your thoughts about the findings that you presented today, and what implications they might have for our kind of public health or public policy in Scotland, or for mental health services. And just be really interested to hear your thoughts about that.
I'm happy to give you a couple of comments, and maybe Chloe will follow up. But I think there's some very clear observations, I think, from our study. The first is that there is a clear appetite in the population at large to be asked about feeling and coping strategies under the extraordinary circumstances that we found ourselves in. So I think we want to ensure that we capitalize on that, noting what Alistair was saying about making sure that user groups are more actively involved in planning, certainly rang true with me. And I think also your question to Alistair early on about how we have got very familiar with the idea of online processes and how to operationalize those moving forward rather than going back to the old way. Make sure that we take the best possible lessons from this extraordinary experience and capitalize on them. And I suppose from a Generation Scotland perspective, we were fortunate that that was the direction we were already heading in. So although it's been enormously challenging for the team to adapt, they've done so amazingly well, and I pay credit to all of them, and not least Chloe, who found herself having to really rethink how we were going to approach this from the job description she got when she was recruited. So Chloe, you might add to that.
Yeah, yes, it was certainly a shock to our system. But one of the things we were sort of fortunate because we were already planning to recruit online anyway. So we everything we were putting in place we were able to use. But one thing that was mentioned earlier that I think we got right with rural COVID life is that speaking to people from the rural community about what was important to them, so that we could then build a questionnaire that we could ask the right questions. And not a huge number of us on the GS team live in rural communities, so we didn't know what was important. So that was the first thing we did with rural COVID life, was go out to participants living in rural communities and say what's important to you. And there was things that people said to us that we had never considered, and some of it wasn't. It was good news. There was positives coming out of it. So, for example, one of the topics we asked about in rural COVID life was about how close you feel to your community. And what we were told and what the data showed us is actually that during COVID, under sort of quite tight restrictions, people in rural communities felt closer to their community and more part of their community than they did before COVID-19. Now, we didn't ask this in our COVID life study, so we don't know if it's the same in more urban settings. I suspect not. But without them giving us that input, we wouldn't have asked those questions, and we wouldn't have found this. There's actually this positive thing that came out of COVID-19, in that rural communities they were able to come together under that setting. So yeah, definitely. The biggest thing I learned from COVID life, the COVID life studies, is how important it is to ask our participants what we should be assessing, what is important to them.
I think the other big message that came out of the Teen COVID Life was how we in Scotland were able to galvanise a very rapid response in the collaboration with the Shine network, already well established in Scotland, and then to go out and get a high level of engagement. And one of the great things that I've seen from that is that what we have done is now going to be worked up as research tools for schools to help support their PSE program, which will introduce them to some of the concepts that we're used to in terms of research. So we're very positive about the fact that despite all of the negatives of COVID-19, we will do a better study moving forward when we do get back to doing recruitment. And I think key to that will be engagement, genuine ongoing engagement that keeps refreshing what the key questions are that we need to ask.
David and Chloe, thank you very much. And I'm just looking at questions that are coming up online, and there's a really nice question, I think, Chloe, that you've almost already picked up, which was about, did you generate any data that you didn't expect? And I think when you were reflecting on rural COVID, the importance of consulting with communities and generating questions that you hadn't thought to answer. And also Nicola, messaged again, sort of similar to my opening question around how do we navigate our ways forward, and you've picked up some of that too. There was a question that asked about, was there and I think you touched on this in the talk, but the variance in responses from kind of COVID life 1, 2 and 3, and somebody asked about the kind of variance in those responses, and did you note anything about the characteristics of those who the characteristics of that variance over time that kind of helps understand those data?
So I think it's worth pointing out that we don't have, this isn't a representative sample, so I think that's important to say. But what we were finding really across the board is that it was designed this way, but we were collecting information from a lockdown to a point where things had eased and to a full lockdown again, and you could quite clearly see these dips and peaks in sort of mood and personality, sort of how people were coping during COVID-19. And although we were seeing, so we found that, so going back to say the age and the sex differences, so although we were finding that female participants tended to report worse mood across the board, you still saw these increases and decreases. So even within male participants, they were still showing a decrease in their moods when there were periods of lockdown, and an increase when it eased. So although you do see these differences in that female participants had higher rates of sort of anxiety and depressive symptoms, it wasn't the case that male participants or older participants were not showing changes across time. It's just the changes weren't quite as severe.
I think one of the other measures that was quite informative, but we didn't touch on, was the standard questionnaire on life satisfaction. It's very standard. Every year there's a survey that goes out and it measures feelings of life satisfaction, and it's been running for many, many years, and it's been punctuated by quite dramatic events like the financial crash in 2008. But when we looked at the life satisfaction measures under COVID, they had dropped to a level that had hitherto not been seen. This pandemic's impact has been greater and more severe and more prolonged than anything that we have seen in the post-World War II era. And I think we need to remember that. I think that there's a lot of talk about the pressure on the NHS, and that's obvious, clear and continuing, but you rightly emphasised, or it was emphasised rightly, that we at the beginning, that it's not just about hospital admissions, it's about the enduring impact on NHS GP practice, and nowhere will that be probably felt more than in the mental health and well-being domain. So I don't want to be negative, but I think that we're doing a good job of getting well prepared, and I think our responsibility as researchers is to try to provide the evidence base that supports the way in which we think about developing policy, and that's certainly part of our objective.
David and Chloe, I want to thank you both very much for inspiring talks and inspiring data. I think one of the, I guess, most remarkable things that have emerged from the pandemic is the way in which, when as a nation, as a public and as a government, we put an effort into research and producing research and making priorities for research. We can make huge changes in research that have direct implications on population health, but also in population mental health. And an important aspect of that you've really brought out today has been the importance of consulting and involving communities in shaping the questions that we ask. So, and I think that's another important lesson moving forward for research and for policy making. And I thank you for that today, and congratulations to you on your research, but also on the expansion of Generation Scotland too. So thank you for joining us today.
Thank you.